Uh, Good evening, ladies and gentlemen. We are on our webinar series of hormonal dysfunction in PCOS, and we look at the various clinical scenarios associated with them. We all know that young girls and women who present to us with PCOS have different symptoms, and these symptoms may vary right from the time they are adolescents to the time they are menopausal and even beyond menopause. Quite a few of them have anovulation followed by erratic periods, amenorrheas, oligomenorrhea, and this delayed period quite often leads to very, very heavy bleeding and causes a lot of distress to women at large. Now, many women with PCOS who have these cycles are also obese. Almost 80% of PCOS patients are obese, and this makes the matters even worse when we have to treat them, because we have to treat their problem of PCOS and at the same time of bleeding following, delayed cycles. But we also have to give them therapies which sometimes may not be the best for them when they have obesity and associated morbid comorbidities. So in short, we are going to discuss today abnormal uterine bleeding in PCOS, and we have with us none other than Professor Nicholas Panay, who is a consultant gynecologist, subspecialist in reproductive medicine and surgery. He's a dear friend of mine from the Imperial College of London and is an NHS consultant with the NHS Foundation Trust, which is with the Imperial College in London. He's an honorary senior clinical lecturer and also a guest professor at the Beijing OBGYN Hospital, Capital Medical University, a board member and general secretary of the International Menopause Society, and the director of International Center for Hormone Health. On a personal note, Nick loves India, loves the Indians here, and more than anything, he loves Indian food, hot and spicy. I must say, I've seen him eating Indian food, and he just loves it. We welcome Nick to this session and to deliver his talk on abnormal uterine bleeding in PCOS women and through the various stages of life in women, right from the adolescent to menopause. And we welcome our digital audience to the session to go through today's program. And if any of you have any questions, you could put in your question in the little box below and type in your question. The questions will reach us, and I'm sure Nick will be very happy to answer these questions once his talk is over. So over to you, Nick, and I look forward to you making your presentation and addressing the audience, which is waiting very anxiously, waiting to listen to you. Go ahead, Nick.
Thank you very much. It's a great honor to be invited to be part of this webcast. And as you say, the topic is abnormal uterine bleeding with reference to the polycystic ovarian syndrome.
Yeah. Excuse me, Nick, if you don't mind, we need you a little louder.
And so the topic of the conversation will be abnormal uterine bleeding with particular reference to women with polycystic ovarian syndrome. And I will start with some definitions, terminologies, and prevalence for abnormal uterine bleeding. So for this, I have used some of the slides from the IMPART course that is administered by the International Menopause Society, because the application of these definitions is universal. So for abnormal uterine bleeding, this is an umbrella term that encompasses...
Nick, your slides are not seen by us. Will you please share your screen? We're not seeing your slides.
Okay. Let me see. Okay, it says that the host disabled attendee screen sharing for some reason.
Can you try it again once more? क्या दिखा रहा है? Okay, now your slides are coming up.
Can you see them?
Yes, absolutely.
Okay, so abnormal uterine bleeding, the definition encompasses heavy menstrual bleeding and intermenstrual bleeding, and it's defined as flow outside of normal volume, duration, regularity, or frequency. As you said, abnormal bleeding in PCOS is common and is frequently due to irregular ovulation. But because it may be due to pathology, it requires proper evaluation and management. So if we just continue with the terminologies, for heavy menstrual bleeding, this is excessive menstrual blood loss, which interferes with the woman's physical, emotional, social, and material quality of life. Intermenstrual bleeding are irregular episodes of bleeding, which are often light and short, occurring between otherwise fairly normal menstrual periods. And breakthrough bleeding is unscheduled uterine bleeding that occurs in women receiving either estrogen estimated around 10 to 30%. In the United States, 1.4 million women annually report AUB, and in the United Kingdom, it is the fourth most common cause for gynecological consultations. And the problem is that this abnormal uterine bleeding can have an adverse effect on health-related quality of life, which is below the 25th centile. It can have both direct and indirect costs, costing around $1 billion a year and $12 billion per year, respectively, for direct and indirect costs. These are the suggested normal limits for menstrual parameters. So in terms of the frequency of menses, if the menses, as often is the case in PCOS, are infrequent, then we are classifying this as more than 38 days between menses. The duration of flow for prolonged is more than 8 days. If it's shortened, then it's less than 4.5 days. And the volume of monthly blood loss is regarded as being heavy if it is greater than 80 mils per period, or light if less than 5 mils per period. The FIGO classification of abnormal uterine bleeding simplifies the understanding of the etiology of AUB, and it's referred to as palm coin. The P stands for polyp, A, adenomyosis, L, leiomyoma, M, malignancy, C is for coagulopathy, O, ovulatory, as it is for PCOS, E, endometrial, I, iatrogenic, and N is not otherwise classified. So the common causes of irregular periods in a woman who would normally be menstruating are hypothalamic, pregnancy-related, menopause-related, age-related anovulatory cycles, and polycystic ovarian syndrome. And with regards to the problems associated with PCOS, firstly, we should refer to the Rotterdam criteria for diagnosing PCOS, which is where two of the three following criteria are diagnostic of the condition. So there should be polycystic ovaries with either 12 or more follicles or increased ovarian volume of greater than 10 centimeters cubed, or oligo-ovulation or anovulation, or clinical endobiochemical signs of hyperandrogenism. This is a typical polycystic looking ovary on ultrasonography. So we know that PCOS is most likely driven by genetic causes leading to insulin resistance and hyperinsulinemia. This leads to an increase in androgen level production, and this can have an impact on menstrual regularity, as well as reducing fertility and resulting in acne, hirsutism, and other problems associated with hyperandrogenism, including long-term increased cardiovascular risk and obesity and hyperlipidemias. But with regards to the endometrial effects and the particular topic that we're discussing today, we know that in a normal ovulatory cycle, during ovulation, progesterone resulting withdrawal from progesterone unless pregnancy ensues leads to a bleed. But with polycystic ovarian syndrome, due to the anovulation, estrogen production continues, and this can result in hyperplasia, and if left unchecked, even carcinoma. And we know that this is one of the potential long-term consequences of polycystic ovarian syndrome if it is left unchecked. So these are the guidelines from the Royal College of Obstetricians and Gynecologists in the UK. So we know that it's good practice to recommend treatment with gestogens to induce a withdrawal bleed at least every 3 to 4 months, and I'll be discussing this later in my presentation. Transvaginal ultrasonography should be considered, and in fact should be mandatory in the absence of withdrawal bleeds or abnormal uterine bleeding. And in PCOS, an endometrial thickness of less than 7 millimeters is unlikely to be hyperplasia. A thickened endometrium or an endometrial polyp should prompt consideration of endometrial biopsy and or hysteroscopy. There doesn't appear to be an association with breast or ovarian cancer, so from this perspective, no additional surveillance is required on a regular basis. These are data from a meta-analysis, which are of moderate quality, showing the finding that women with PCOS have almost a 3-fold increased risk for endometrial cancer. As you can see here from the forest plot, the risk of endometrial cancer favors PCO rather than the control. In terms of making the diagnosis, so if you have somebody in the clinic who presents with abnormal uterine bleeding, again, these are slides I borrowed from the IMPART set. We know that we have to take a very careful menstrual history, looking at when the last menstrual period was, the frequency, regularity, duration, and volume of the menses, and also inquiring about intermenstrual or postcoital bleeding. A careful sexual and reproductive history is important, inquiring about pregnancies, fertility desire, subfertility, contraception, previous STIs, and smear history. Associated symptoms that have to be considered are whether there is pain, any discharge, any bowel or bladder symptoms, and then systemic inquiry should include inquiry about weight changes, coagulopathy, PCO, past history of course, liver, renal, thyroid, pituitary, adrenal disease, and drug history. In performing the examination, we should of course do basic observations of blood pressure, body mass index, looking for signs of pallor, anemia. Are there signs of systemic disease, thyroid disease? Is there a sign of coagulopathy in those that are bleeding heavy, such as bruising or petechiae? Any signs of Cushing's syndrome, so centripetal obesity, signs of hyperandrogenism, hirsutism, and acne. And an abdominal and a pelvic examination would be indicated with abnormal uterine bleeding, ensuring that cytology is up to date, and also perhaps doing a chlamydia screen where there is intermenstrual bleeding in case the bleeding is due to infection, and an endometrial biopsy may be required according to the index of suspicion of endometrial abnormality. In terms of the investigations, then we should ensure that hemoglobin has been done and that there isn't sign of iron deficiency through a ferritin level. Thyroid function tests, estradiol, gonadotrophins, androgen levels, SHBG, prolactin, and HCG. Pregnancy is suspected, and also looking for signs of coagulopathy if there is concern about heaviness of bleeding and a family or past history of coagulation disorders. Ultrasonography is mandatory. MRI isn't, but if there is uncertainty about the findings of ultrasonography, then an MRI may be of use. And hysteroscopy is required where ultrasound findings are inconclusive or where thickening of the endometrium has been found or there is a suspicion of polyps or fibroids or other endometrial pathology. I prepared some top tips that, in my experience, I think are useful in determining the timing of investigations and also the usefulness of hormonal investigations. So with regards to estradiol and FSH, we're looking at ovarian reserve, or even if we're looking at signs of hyperandrogenism, a follicular phase hormone profile in the early phase is particularly helpful. It can be difficult to time it, of course, in women that have cycle irregularity. We know that estradiol levels are usually well preserved in polycystic ovarian syndrome, but there are a subset of women who are the thin polycystic ovarian syndrome, women who tend to have low estrogen levels, and these need to be observed carefully, particularly in terms of adequate replacement of hormones to preserve their bone density and cardiometabolic health. Androgen levels, it's important to look at not only testosterone but SHBG, and we work out the free androgen index of testosterone times 100 divided by SHBG, and typically if the FAI is greater than 6%, then this is suspicious of polycystic ovarian syndrome. If mainly DHEAS is elevated, then we may need to perform adrenal investigations as well, and also progesterone in case we suspect congenital adrenal hyperplasia. In terms of the ultrasound scan, I think a post-bleed ultrasound is particularly useful because if we perform scans later in the cycle, then the endometrium will be thickened anyway. So an immediate post-bleed ultrasound will show if there is persistence of endometrial thickening. In terms of ovulation, then clearly we have to try and time it to the luteal phase of the cycle, but that's assuming that the individual has a regular cycle, of course. Prolactin levels, we know mild hyperprolactinemia is not uncommon with PCOS. They can also go up with the stress of the test. And of course, we should look at macroprolactin levels to ensure that what we're assessing is monomeric prolactin and not macroprolactin, which is of less significance. In terms of transvaginal ultrasonography, we're looking at the sum of two adjacent endometrial layers to give the endometrial thickness, referred to as the endometrial echo complex. If there is sonolucent fluid there, then the thickness of the fluid echo is subtracted to give the endometrial thickness. If irregularities are seen or if the endometrium cannot be evaluated adequately, then additional investigations are warranted. And of course, a thicker endometrium is associated with a greater risk of endometrial polyps, hyperplasia, and malignancy. Now, typically, in a postmenopausal woman, an endometrial thickness of more than 4 millimeters would warrant further investigation. If you're going to go by that measurement, then it should be an immediate postmenstrual scan in women who are in perimenopause or who are cycling normally. But in terms of PCOS, there have been a couple of studies performed in order to determine when endometrial biopsy should be performed. So this was a study looking at ultrasound and menstrual history in predicting endometrial hyperplasia and PCOS. 56 women with PCOS presenting with infertility due to anovulation underwent both vaginal ultrasound assessments and biopsies. 36 PCOS patients, so that's 64%, had a proliferative endometrium, and 20, so that's 35.7%, had endometrial hyperplasia. 5 of the latter had cytological atypia. But the conclusion from the study was that endometrial thickness less than 7 millimeters or intermenstrual intervals of less than 3 months, corresponding with 4 or more menstrual periods yearly, was associated with proliferative endometrium only. A study performed subsequent to that, one in 33 women with PCOS, looked at the endometrial stripe measurement by ultrasound. Hyperplasia was noted in 10 of the 33, giving a 30% hyperplasia incidence. Patients with hyperplasia had significantly higher body mass index than those without, and for every 1 millimeter increase in endometrial stripe, the odds ratio of hyperplasia increased by nearly 1.5. So in the previous study, a 7 millimeter cutoff was suggested, which would give 100% sensitivity and 27.8% specificity for hyperplasia in patients with PCOS. But a higher cutoff in this study was suggested of 9.35 millimeters in patients with PCOS because it had a comparable sensitivity of 100%, but a superior specificity of 56%. So this research group suggested routine ultrasound screening with biopsy, a thickness of 9.3 millimeters, to detect endometrial hyperplasia in obese patients with PCOS. Now, where there is diagnostic uncertainty and where the facilities permit, a saline infusion sonohysterography may be performed, which more accurately evaluates the endometrial cavity. It does require a gynecologist to perform this, and it's not available in all centers, but it is more sensitive than transvaginal ultrasonography in detecting focal abnormalities in postmenopausal bleeding. And so you can offer this, then it may avoid the need for hysteroscopy and biopsy, but if it's not available, then hysteroscopy is mandatory if there is suspicion according to the findings of the transvaginal sonography. And we know now that hysteroscopy can be easily performed in the office setting using vaginoscopy with little or no anesthesia. It has a good diagnostic accuracy for hyperplasia and lesions such as polyps and leiomyomas. And if available, an office hysteroscopy is preferred by women rather than having to undergo a general anesthetic. But not in all cases. Some would still prefer to have a general anesthetic, of course. And the advantage of hysteroscopy is that operative techniques can also be performed that will allow control of the uterine bleeding. For instance, resection of polyps or fibroids, or even an endometrial resection. So I just put this image in this slide to show what a hyperplastic endometrium looks like. And once the woman has been given adequate progestogens, then this endometrium can be returned to a normal thin endometrium, which you can see there at the fundus of this uterus. So I'd now like to move on to interventions, and all the guidelines, including the RCOG, the NICE guidelines, the recent Monash guidelines, emphasize the importance of exercise and weight control, and it's recommended that lifestyle changes, including diet, exercise, and weight loss, are initiated as the first-line treatment for women with PCOS for improvement of short-term and long-term outcomes, and should precede or accompany pharmacological treatment. So lifestyle and dietary interventions should underpin treatments that we advocate for managing issues such as abnormal uterine bleeding. So in women with PCOS, intervals between menstruation of more than 3 months may be associated with endometrial hyperplasia. So it is important that we induce a withdrawal bleed regularly with cyclic gestogens for at least 12 days, or protect the endometrium with an oral contraceptive pill, or by exposure to intrauterine systems such as the levonorgestrel intrauterine system. The problem that we have is that the most effective regimen is unclear due to the lack of randomized clinical trial data. But what I want to do is, using this slide from IMPART, I want to highlight some of the advantages of endometrial proliferation. And in those women with heavy bleeds, it reduces both the duration and the amount of menstrual bleeding. And there is even evidence that it can transform hyperplastic endometrium into normal endometrium. And of course, it's important, if hyperplasia has been diagnosed, that a repeat endometrial biopsy is performed, typically within 3 months of insertion of the intrauterine system. And it usually is possible to perform a Papel sampling of the endometrium, even with the Mirena in situ. The advantage of the combined oral contraceptive pill, again, is that it corrects menstrual irregularity and it will reduce any excessive bleeding. If there is excessive bleeding, then the extended cycle called continuous COCs are more effective than the cyclic COCs. And my preference in PCOS is to use a 3rd or 4th generation combined oral contraceptive pill, which is less androgenic. And I will talk about that a bit further in the presentation. In terms of progestogens, cyclic progestogens can be used, such as MPA, cyproterone acetate, or dydrogesterone at a dose of 10 milligrams per day for 14 days every 1 to 3 months. If Depo-Provera is used, then amenorrhea rates as high as 90% can be achieved, but that's not necessarily the ideal progestogen to use in the context of polycystic ovarian syndrome. And we know that in women with high bleeding volumes, cyclic oral progestogens can reduce bleeding by 30% if it's due to anovulatory cycles. GnRH agonists very rarely have to be used as a first-line treatment, but in those women, particularly with high androgen levels that have been resistant to other forms of treatment, can be potentially used with some add-back hormone therapy, and can also be useful for those women with endometriosis and also cycle-related premenstrual symptoms, or PMDD. If a woman is approaching the menopause, past history of PCOS, then menopause hormone therapy may be the treatment of choice, and that will control bleeding and hyperplasia. Tibolone is not a particularly good choice in this population because there is often breakthrough bleeding, and it's also quite androgenic, so it can exacerbate androgenic symptoms. I put this slide up really to demonstrate that the Mirena doesn't necessarily work straight away in terms of controlling bleeding problems, and it can take 3 to 6 months to do so. And therefore, it's important that we counsel our patients about the fact that they have to be patient with it. In my experience, if the Mirena has not settled down the bleeding within 6 to 12 months, then it's unlikely to work beyond that. And certainly, patients will have lost their patience by then if it hasn't worked by then. But sometimes Mirena doesn't work because perhaps the patient wasn't properly evaluated in the first place. This is a fascinating paper published a little while ago now, looking at why Mirena didn't work at times, because it is very effective. And they looked at women who went on to have a hysterectomy. And in this pathology specimen, we can see that the reason this Mirena didn't work was because there was a great big submucous fibroid within the endometrial cavity, which unfortunately wasn't diagnosed because an ultrasound had not been performed prior to Mirena insertion. So I think it is almost mandatory to perform ultrasonography before Mirenas are inserted, in my view. So what are the benefits of the pill? in PCOS, as I've mentioned earlier, it will control bleeding irregularity and it will prevent endometrial hyperplasia. But of course, with modern pills containing more progestogenic progestogens and anti-androgenic progestogens such as drospirenone and Dianogest, it will reduce androgenic symptoms as well. And in some countries, Yaz, or Eloine as it's called in the UK, is licensed for the treatment of moderate acne as well as providing contraception, and is also licensed for controlling symptoms of PMDD, severe PMS. Another option is the estradiol-delivering pill, Clara, which is particularly useful for women in the perimenopause seeking contraception who want to try to provide themselves not only with good cycle control, good bleeding control, but also an element of hormone add-back or hormone replacement. And of course, restoration of the hormonal balance, reduction of androgen levels is particularly important in terms of reducing insulin resistance, metabolic syndrome, protecting against the long-term effects of cardiovascular disease, and also providing for those women who are hypoestrogenic protection against osteoporosis. So the question is often asked about insulin sensitizing agents such as metformin and myoinositol, and should we be using those routinely in terms of controlling the symptoms of PCOS? In the context of bleeding, there is some evidence that you can see some improvement in menstrual pattern in women using insulin sensitizing agents for the improvement of bleeding problems. But really, the effectiveness of metformin in doing that is not as good as using hormonal preparations. So this was an early systematic review and meta-analysis of 4 RCTs over 100 subjects, where they looked at COCP versus metformin and found that the pill was superior to metformin in improving the menstrual pattern and reducing testosterone, even though in the initial phase metformin was good at reducing fasting insulin resistance. And as you can see, there was insufficient evidence for the impact on other symptoms and conditions listed there. What about the data regarding the use of progestogens with or without estrogen for irregular uterine bleeding associated with anovulation? Well, this is a review performed on behalf of the Cochrane Library by Martha Hickey, Jenny Hyam, and Ian Fraser. And disappointingly, they did not find any randomized evidence that was relevant to their clinical questions. The studies were just not of a sufficient standard in order to perform a systematic review and meta-analysis of the data. And they quoted the problems of sex steroids being associated with treatment for oligo and anovulation, leading to different regimens, different bleeding patterns, and highly variable studies where the outcome measures were very difficult to unify. And of course, the decision regarding a progestogen is likely to be affected by the patient age, medical history, and of course the fertility wishes of the patient. So the implications for practice from this Cochrane review was that it remains unclear how irregular menstrual bleeding associated with oligoanovulation should be best treated, because there are no randomized evidence data currently available about the most effective type dose regimen and administration route of progestogen, or the relative efficacy of progestogens used alone or in combination with estrogen. So we know that progestogens do work, but it's just that we lack comparative data. And so the implications for research is that we need randomized controlled trials of progestogens, either alone or in combination with estrogens, in order to define the relative efficacy and acceptability of these interventions regarding menstrual bleeding. And particularly, trials are needed to compare different cyclic progestogens with the oral contraceptive pill in irregular bleeding associated with PCOS, and oral versus intrauterine progestogens in perimenopausal irregular bleeding. So I just want to now leave you with some take-home messages. And I think the NICE guideline from the UK is quite useful to summarize some practical take-home messages on the subject of PCOS and the associated abnormal uterine bleeding. And then perhaps we can have a discussion about the practical management of patients in your practice. So with regards to the oligo or amenorrhea, which occurs with PCOS, if the woman has prolonged amenorrhea, less than one period every 3 months, abnormal vaginal bleeding or excess weight, then we should prescribe a cyclic progestogen, such as MPA, 10 milligrams per day for 14 days to induce a withdrawal bleed, and then refer for transvaginal ultrasound to assess endometrial thickness before the progestogen is started, so we get a baseline measurement. And then if there is any concern about the endometrial thickness, if it's greater than 10 millimeters, or if the endometrium has an unusual appearance, then we should refer for endometrial sampling to exclude endometrial hyperplasia or malignancy based on the guidelines that I've previously discussed. Now, if the endometrium is of a normal thickness and appearance, then advise treatment to prevent endometrial hyperplasia. So even if the endometrium is normal, I think it is still important that women are treated prophylactically against developing endometrial hyperplasia if they don't have regular periods. And of course, the choice of treatment will depend on factors such as whether the woman wants to have regular withdrawal bleeds, whether she has acne or hirsutism, and whether there are any other contraindications to treatment. So we've talked about cyclic progestogens, the contraceptive pills, and also the levonorgestrel intrauterine system as being the most common interventions. But of course, the most important thing that we should always emphasize is to encourage a healthy lifestyle to reduce not only bleeding problems, but the long-term complications of PCOS, and advising weight reduction in women who are overweight or obese. One of the points which NICE makes, which I've qualified slightly, is that osteoporosis prophylaxis is not routinely required for women with PCOS who are amenorrheic. That's in women who have adequate estrogen levels. But if they do have low estrogen levels, then there may be a benefit to using hormone therapies, such as the pill, in order to provide protection against osteopenia and osteoporosis, as well as protecting their endometrium. So the take-home messages are that irregular menstrual cycles are a common occurrence in PCOS. This makes it difficult to define and recognize abnormal uterine bleeding, so it's useful to have a low threshold for investigation if there is suspicion about the endometrium. Women with PCOS, oligoamenorrhea, are at risk of endometrial hyperplasia and should therefore be diagnosed and treated promptly to prevent endometrial problems. And I see too many women that present to us very late on, by which stage they have hyperplasia. And we need a structured approach to assess AUB, which includes history, physical examination, and tests to assess blood loss and detect underlying pathology. And of course, therapy should be based on the patient's goals, including cycle control, fertility, reduction in bleeding, minimizing blood loss, and a desire for improved quality of life. And I've just provided some guidelines here from the UK, the RCOG Green Top Guideline, the NICE UK Guideline, and from Verity, which is the charity for women with PCOS. I think these, in addition to the recent Monash guidelines, are the most useful guidelines for guiding our management of this distressing condition. Thank you very much.
For this excellent talk and providing all the background of what really happens with PCOS and the abnormal uterine bleeding which occurs. I think we face young girls right from adolescence coming with abnormal uterine bleeding, where we have confirmed, we have done all the possible investigations. We are taking for granted, we have ruled out pregnancy, we have ruled out any pathology in the pelvis. We have ruled out any other endocrine disorder, and we have come to a conclusion that this girl has PCOS. She's 18-year-old. She's having difficult periods. She misses periods every 2-3 months, and then she bleeds profusely. So when a young girl comes like this to you, what is the first, sort of management you try doing before you proceed with any hormonal therapy?
Well, I think the most important thing is to take a careful history in terms of the lifestyle that this young woman has. So does she have a well-balanced diet? Is she getting regular exercise? In my service, we also have a dietitian who works closely with us. And I always recommend, even if they say that they think their diet is okay, that they see the dietitian, because there may be 1 or 2 things that they're missing. And there's quite a lot of argument as to what is the perfect diet. Is it low GI diet? Is it Atkins diet? Is it paleo diet?
Fasting.
I think
intermittent fasting.
5-2 diet. I think the most important thing is that nutritionally, that there is representation from all the nutritional groups, that there aren't vitamin sort of deficits or deficiencies, whether that individual is vegan or vegetarian or has meat as well. And also, as well as the diet, ensuring that that individual is not smoking, because that can quantify the risk, amplify the risk as far as cardiovascular disease is concerned, and making sure that they're limiting the amount of alcohol that they're having, if any. In terms of the exercise, we also work closely with a fitness instructor who gives advice about making sure they get adequate exercise, even if it's only just walking. But there's quite a big sort of popularity now for Pilates, for instance, and yoga. Even though these are not high-impact exercises, they're still, I think, very important. And we know that just very small changes, a 5% reduction in body mass index, can have a significant cardiometabolic benefit for these individuals. And then, of course, having established that she's doing as much as she can, she's young, we need to also talk to the family as well, because often they're influenced by what their parents and what their siblings are doing. And, look at the sort of setup they have at home. Are they having good quality nutrition, or is it a family where perhaps they're having quick sort of ready meals, etc., which are often high in sugar and fat and salt. So we bring in the parents as well into the conversation where it's appropriate to do so.
Yeah. So I think a lot of lifestyle change will definitely help an obese girl who's probably having delayed periods and bleeding heavy. But at the same time, we do have lean PCOS also. And then what do we advise them? So if they are having irregular periods, they are bleeding heavy, what do we do with them with lifestyle changes?
Well, lean PCO is more of an issue. And I would say that that's where, having established that they're not lean because they have been trying to diet too much, perhaps, and have lost too much weight, and their irregularity of their periods isn't necessarily due to PCO, it may be due to hypothalamic amenorrhea. That's something that we have to be mindful of. I have patients where it can be difficult to differentiate between hypothalamic and PCO, and sometimes you see a combination of both. This is where we have to intervene perhaps earlier with hormonal support, because as I said in my discussion, although most women with PCO have good estrogen levels, they're not at risk of losing bone density. In these younger women, their risk of not reaching their peak bone mineralization, as well as having cardiometabolic issues. And so it's important that we intervene with appropriate hormonal support sooner rather than later.
Yeah. So I agree with lean PCOS. We do get patients with very low estrogen levels. We get their endometrium. If you do it, they're bleeding, but when you do their ultrasound, you'll find the endometrium very thin. And on the other hand, you'll find some patients with very thick endometrium and bleeding very heavily. So in short, when we are managing,
with regards to the thin endometrium, people think that just because someone has a thin endometrium, they don't bleed. But we know if the endometrium is too thin, then you can also get bleeding due to capillary fragility and due to support of the framework, the support of the endometrial capillary. So they may not have heavy bleeding, but they may get a constant spotting in that situation. And again, that's where hormonal treatment to thicken up that endometrium in a healthy way may be of some benefit.
Yeah. So in short, when they have acute bleeding episodes, before we can put them on any hormone therapy, is there anything we can do in the meantime of using hemostatic agents? And if we do use them till we can sort of completely evaluate them and know what to start for them. If we use something, do you tend to use any hemostatic agents to help them in the meanwhile?
Yeah, as a temporary measure, not as a long-term.
Yeah, temporary.
If I have somebody with heavy bleeding, then we favor tranexamic acid. So we usually start a dose of 500 TDS, up to a gram TDS can be used. If on the other hand, they may have some pain as well as bleeding, then we may use non-steroidal anti-inflammatory like ibuprofen, for instance, 400 milligram TDS to provide them with some bleeding control. That won't be as effective as the tranexamic, which will reduce bleeding by up to 50%, but will also address the pelvic cramping that they often have in that situation.
Absolutely. We do have combinations of tranexamic acid with mefenamic acid, which helps to relieve the bleed and the pain together with taking just one tablet. So I think it works well when you have a combination also to take care of that current episode of heavy bleeding. But if you would have to, say, treat a young girl and decide whether she needs only progesterone therapy or she should be put on oral contraceptive therapy, which would be your choice, first choice?
I think my choice will depend on the scenario. So if that particular individual desires of contraception, then you would tend to go down towards a pill route. If all they want to do is control their bleeding and they have normal estrogen levels, then I will guide them towards progestogen usage. So it really depends on the scenario. And usually you will be guided by the individual herself, who might say, I don't want anything with estrogen in it, so I don't want to go on the pill, or I've had side effects with the pill before, breast tenderness, weight gain, whatever, just give me something that's less likely to give me side effects. On the other hand, as I said, you may have somebody who wants to be assured of contraception, even though they may not be having regular periods, or they may be the hypoestrogenic group that requires some estrogenic support, as well as ensuring protection of the endometrium, and that's where the pill would be more appropriate in that situation. I'm not sure if we have it available in India, but the Clara or the Zoli pills, there is a supply problem at the moment, which delivers natural estradiol, sometimes has a good effect in these individuals because metabolically, I think the estradiol is probably a little better in terms of bone protection and reduction of insulin resistance than the ethinyl estradiol in the traditional pill.
But the biggest challenge remains is if we have an obese PCOS and she is, high on her lipids, and we are concerned about giving them estrogen therapy.
Of course, and this is where if you have somebody with a high BMI, then you may want to avoid using ethinyl estradiol, which potentially would have a prothrombotic effect in that individual and could predispose to VTE and even stroke. So you may not be able to introduce a contraceptive pill until they have managed to lose that weight. And that's where the cyclic progestogen or an intrauterine system, such as the Mirena, for instance, would be of greater preference.
Yeah. If you look at the girls in India, if they're about 17, 18, probably many of them may not be sexually active. And then in that case, putting in an IUD, it becomes an issue wherein we really can't insert it to help endometrial protection or to make them bleed less. So in those cases, would you give Depo-Provera to such girls?
It's an option, but it's not metabolically, I would say, MPA is not metabolically the best progestogen, but potentially as a temporary measure until they've managed to hopefully achieve some weight loss. But I think my preference would be to try to give them something that won't necessarily give them contraception, but at least will get them through the most difficult phase in terms of their bleeding problems and enabling them to have adequate endometrial protection until they've lost weight and then can go on to something which perhaps is metabolically better. But Depo-Provera is an option that I wouldn't exclude as a possibility. Sometimes with Depo-Provera, they become, as you know, quite hypoestrogenic, and perhaps also it impacts on their bone density as well. The bone density will recover typically with time when it's discontinued, but it wouldn't be unusual perhaps to add back a little bit of estrogen in that situation and monitor their endometrium by ultrasonography. Can I also say that one other intervention which I found particularly useful in the obese polycystic woman with hirsutism and acne, particularly where they're very distressed by that, is to use cyclosporine acetate with, of course, contraceptive cover, barrier methods if required. But in that situation, using cyproterone acetate 25 to 50 milligrams per day for 3 out of every 4 weeks for 3 months can really reverse those distressing skin symptoms that they often get and put them back on track.
Yeah. As a matter of fact, today I had a young girl who's got high androgens, and of course we have ruled out adrenal issues. But she's complaining a lot of hair loss on the frontal region of her scalp, right from here, a receding hairline. She was on the pill for quite a few years. She did well with it. But now when we investigated her, we found that she has a very high platelet count. Her platelet count was somewhere around 7 lakhs. And that alerted me, and I said, she was seeing someone else before, and when I saw all her reports, they were all with high platelet counts, with a low HDL, high platelets, and she was put on an anti-androgen like flutamide, but did not help her over a period of 3 to 4 months. So the concern is she's insisting that she needs to be started on the OC pill. What would you do in such a case?
Well, given that she's potentially higher risk for thrombosis, I would, if I was considering estrogen, I would go with the transdermal route.
Yes.
And use transdermal estrogen with a natural type of progesterone, either dydrogesterone or utrogestan. I think we can be fairly confident that because of the avoidance of first-pass metabolic effects, either with a gel or a patch from the estrogen, then she will have that potential estrogenic benefit, hair loss, but at the same time avoiding a prothrombotic effect.
Yes. We unfortunately don't have patches in our country, but we do get transdermal gel. And estrogen
gel is equally good as patches. And in fact, the young women tend to prefer the gel rather than the patches, because they often say, well, patches is what my mother wears, I prefer and not to have anything showing that I'm on any hormones. Actually, you may have heard that in Europe, particularly in the UK, we have big problems with patch supplies at the moment. So most of our patients are being prescribed gel rather than patches.
Yeah, No, as a matter of fact, we did get patches come into our country when we were campaigning for menopausal women to have transdermal estrogen. We did get it from Novartis, but after we used it in India, we found because of the humid conditions, the patches would come out within 2 to 3 days and would not last for 4 days. And secondly, we almost 25% of our patients develop some rash or irritation. And then after a few years, I think Novartis withdrew the patch from India because it just didn't seem to sell or market, sort of be utilized well by women. So, but the gel is working well, and we've been using gel now instead of a patch. Though gel is more nuisance factor rather than the patch, because patch you stick it on and it's on for a few days, while the gel you need to apply more often. So I think that's the issue. Now there's another question which has come up, wherein someone has asked that there's a PCOS woman, of course now she's in the older age group, she's obese and she has impaired glucose tolerance. And she wants to know whether it's safe for her to use the LNG system in such a patient if she has a impaired glucose tolerance, sometimes going into, actual just a sort of a diabetes situation. So would you recommend an intrauterine device with, of course, a minimal dose of progesterone which is being released, but mainly because it's an intrauterine device, also whether it's safe for her to use it? That's a question we have got from someone.
Is it safe for her to use it? The release of the progestogen is mainly local, it's the equivalent of 2 to 3 mini pills per week. There's no prothrombotic risk. It shouldn't deteriorate her metabolic condition, although it won't improve it either on its own. But it will provide her with a very effective contraception and endometrial protection. If she has low estrogen levels, then a transdermal estrogen could be combined with the IUCD, which will improve the situation metabolically for that individual. Clearly, that's not required if she has quite high estrogen levels anyway. Again, if you want to minimize the systemic effect of the progestogen, which sometimes it can be in the first 3 to 6 months, then we have the new intrauterine systems which are now available, JDES and Kylena, which release significantly less progestogen, and although not tried and tested in this situation, I believe give adequate endometrial protection. Where we have fitted them, we do scan the individuals and they seem to adequately protect the endometrium.
That's good. Any role for Dynogest in such women?
So we don't have Dynogest on its own, which is Vizan, which is licensed for endometriosis treatment. We don't have that in the UK. I think Dynogest is a nice progestogen. It gives endometrial protection and is anti-androgenic. It's not as anti-androgenic as drospirenone, but nonetheless it still can be of benefit in women who have symptoms of hyperandrogenism. Again, it would depend on what their estrogenic environment is as well, because you may need to give estrogenic support. I do have a patient on Vizan who was obtaining it from Germany, who I added back some estrogen gel, and I think that combination has proved to be very successful. The other possibility of using Dynogest is within the Clara pill, where it's combined with oral estradiol in combination with Dynogest in a 4-phasic regimen. The other thing I'd like to say is where the pill is being used, if you want even greater endometrial protection, then sometimes we use the pill regimens back to back rather than with a hormone-free interval. Of course, that won't allow for a withdrawal bleed to occur, but you know that the endometrium is going to be even more effectively protected. And if you're using an anti-androgenic progestogen in that context, it works the whole cycle, so they don't get recurrence of their skin problems during the hormone-free interval.
Yeah, absolutely. There is a question that, of course, this is not it's a PCO patient, but the lady has a bleeding diastasis at the same time. She's suffering from a bleeding disorder. So when she menstruates, she bleeds very heavy. Now, in this girl, she needs to be given or probably the oral contraceptive pill as a continuous pill so that she reduces the amount of periods. Or she could get the Mirena could be put in, which would be great for her. So these are the various possibilities which she could have. So the question is that if she has a bleeding tendency, the best thing for her would be to, of course, prevent a period coming in too rapidly, right? Try and reduce the amount of blood loss by probably giving her the OC pill continuously for 3 months and then having a bleed, which will help to prevent her hemoglobin dropping too low. Because every time she bleeds, she drops her hemoglobin to 7 grams.
Well, I would favor using the OCP continuously in that individual.
Exactly.
Without a break at all.
Yes.
Now, there is a situation when we use the pill continuously, as I'm sure you know, that sometimes they do get a little bit of cramping or breakthrough bleeding that just doesn't settle. And in that situation, I instruct them to have a 4-day break from the pill, allow for a period to occur, and then restart again. And during that break, if the period is heavy, then to cover themselves with some tranexamic acid, or the preparation with mefenamic that you've mentioned.
Yes. So that's exactly what probably even I would do. And the question usually comes up from the mothers of these PCO girls. Doctor, how long do I need to give the OC pill? I mean, it's a standard question which every mother will ask for her adolescent girl who's maybe 16, 17, and you keep giving them the pill. And that's a question.
So my standard response is we don't put arbitrary limits on the duration of use of the treatment. I think we have to try to individualize it, and it depends on the parameters that we're looking at in terms of the PCO itself. So is there evidence that that individual has been successful in achieving weight loss and reversal of the metabolic condition, in which case there is a greater likelihood that the menstruation will return to normal. At some stage, we need to then try a period, or try a phase, if you like, rather than pill, without the pill, and see what happens with regards to the menstruation. But I have to emphasize that these are treatments and not necessarily cures, and that the can return when it's discontinued. I think what they want to know is that this is not doing any long-term harm to their daughter, either in terms of the metabolism or their fertility. And I think the old concern that if you're on the pill a long time and then you come off and the periods don't return, is somehow adversely affecting your fertility, is still there. And we have to counsel them that, if anything, being on the pill long-term is going to be protective a little bit towards ovarian reserve, not actually reduce it. Of course, the problem that we have is when they're on the pill, because it reduces AMH levels by 30%, and we know that it suppresses FSH production, that we cannot assess ovarian reserve in that situation. And that's another situation where they may need to come off for 3 months to assess whether they're ovarian reserves, and particularly as they're getting into their mid-30s. If they're, of course, the time that they would come off is the time that they want to try for a pregnancy, or they may be switched to Clomid or to Femara or ovulation induction with gonadotropin.
Yeah. So that's what we are finding very often now, that people tend to do the AMH levels, for almost we have a lot of private sector here wherein everyone is anxious and the consultants are doing investigations pretty rapidly. So a woman who's been on the pill and she's concerned, they do the AMH. AMH is obviously it is showing a little suppression. They say ovarian reserve is poor, you need to go into IVF, you need to have a baby soon. So this is the constant problem we are having, and I think the message should go out that occasionally when the patient is on the pill for a long time, she will manifest with a low AMH at some point. And when one stops the pill, over a period of time, you'll find the AMH coming up quite well, and they have a spontaneous conception. So as a matter of fact, that's one area I've found in quite a few patients, that their AMH level gets suppressed when they've been on a long time pill.
And as you said, it can take a while for the AMH to recover, so they really should wait at least 3 months before coming off to have it, if they're going to have it retested.
Absolutely. So now we switch from the adolescent and we go into the the menopausal age group or the perimenopausal age group, wherein these women have again, the PCOS women in the reproductive age group, somehow when they've reached their 30s, they tend to become normal. Their periods start coming on time, which they were not coming before, and they behave pretty normally at that age. But once they touch again 40, 45 plus, they start getting their delayed periods. Probably they become obese, they've developed metabolic syndrome, and now they are having these heavy periods. Now, what would you do as a long-term protection for them to prevent, look for hyperplasia? How would you look for it? Of course, you'll do an ultrasound day 4, 5 of the period. And if she's thick on endometrium, which is a test you like to do, would you rather do a hysteroscopy, or would you do an endometrial sampling, or would you do a saline hysteroscopy?
So for me, it's easy because I work in a unit where we have ready access to outpatient hysteroscopy. So I will normally, if I'm concerned about the endometrium, do a hysteroscopy using the 2mm J&J hysteroscopes. The patients find that very comfortable, probably more comfortable than having a Pipelle sample. And of course, the Pipelle, the cornea sampler, does not sample the whole cavity. And so it's possible that pathology may be missed by that. But of course, we have to be realistic that in the real world, in primary care, not everyone's going to have easy access to hysteroscopy. And so I think it's reasonable in general practice to perform a Pipelle initially, but if the problem then persists, or if the scan findings are particularly concerning, then under those circumstances, refer for a hysteroscopy. Again, I think that if you can offer an office hysteroscopy rather than giving the patient a general anesthetic, then it's justified to have a lower threshold to do a hysteroscopy. But if it's the difference between doing a Pipelle or having to give a general anesthetic, then I think a Pipelle, again, is a very reasonable starting point.
Yeah, right. So with women who are, having these heavy periods, have you ever used in a situation where she's bleeding very heavy and she's not happy to go in for a surgical procedure, like a hysteroscopy or a further investigation? Have you ever used a GnRH analog to help?
I do, and I did mention it in my presentation, that I think it does have a role. Where the cycle-related symptoms are very severe, it may be not just bleeding, they may have PMS symptoms, they may have possibly some endometriosis or adenomyosis, and this is where a GnRH analog can really transform their life because it brings all of that to a very rapid sort of resolution. But we don't want to replace cycle-related symptoms with menopause symptoms. So I think also it's important that we get the add-back hormone therapy right. I'm a big fan of the bioidentical hormones. I'll use a transdermal estrogen with natural progesterone. But sometimes if women are not suffering with hyperandrogenism, then perhaps they might do better with tibolone. Because one of the things that I've noticed, and I'm sure you have as well, is women with polycystic ovarian syndrome who often have a good libido when their androgen levels are high, tend to miss it more as their androgen levels drop through the menopause transition than those women where their androgen levels were low to begin with.
Yeah.
So using something like Livial, tibolone, or even testosterone replacement can really improve their quality of life. But yes, I think GnRH analogs definitely have a place, as long as we're monitoring their bone density as well, making sure we don't put at risk.
So as a temporary measure, that's what I was suggesting, just as a temporary measure till you can get things done. How often have you resorted to hysterectomy in such patients?
Well, not that often. It depends on the circumstances. So if we have somebody who perhaps has a history of PCO, but also has fibroids or a history of endometriosis or PMS, then that's where a hysterectomy, I think, can be an extremely effective way of restoring their quality of life. And we know that these women, as long as they get adequate add-back hormone therapy after the hysterectomy, assuming the ovaries are removed as well, then they do extremely well. The question then is, do we remove the ovaries as well at the time of the procedure? And that will depend on whether it is purely a bleeding problem or whether they have cycle-related symptoms or cycle-related pathology. If it's purely a bleeding problem, a hysterectomy will suffice. But if there are cycle-related issues, then if you leave the ovaries, they can continue to get those problems in the absence of menstruation.
But with abnormal uterine bleeding, where there is no uterine pathology, there is no other problem, most of the times I think we are able to manage with all these conservative therapies rather than resorting to hysterectomy.
And we mustn't forget that endometrial ablation is a very effective tool for not necessarily creating amenorrhea, but at least reducing the bleeding. We know it's 90% effective to do that. And you know, with the electrothermal ablation, we're looking at around 50% amenorrhea rates. It's not as effective where there is adenomyosis, though, and that's where an MRI might provide some additional useful information in decision making, as well as performing an ultrasound, or you may want to perform a 3D ultrasound.
Because I think their dysmenorrhea would just continue even after doing the ablation. They could control the bleeding, but the dysmenorrhea would continue.
And often the bleeding as well, because they have deep endometrial pockets that the ablative intervention cannot get to. So in that situation, a hysterectomy may be a better option, or a Mirena than performing an ablation.
Right. So I think there are so many questions, Nick. I don't know how I'm going to complete because they've completely run out of time, and I don't know if I can get a few more minutes. Can I? I'm asking my. You have 5-10 minutes more, Nick?
Of course.
Sure, good. But I'll ask a few more questions because there are so many, and I think we need to respond to most of our people who are watching the program. And I think there's one question here is, what is the equivalent dose of gel with estradiol? Probably the question is related to taking an oral estrogen tablet as compared to the gel.
Yes.
What is the equivalent is what they're asking you.
And we're talking about the pump gel, estrogel, or the Sandrina?
No, the application.
The application, yes. So each pump of estrogel is equivalent to around 0.5 milligram of estrogen. So if you have somebody on 1 milligram of estrogen, then they need 2 pumps of gel. 2 milligrams, they may need 4 pumps of estrogen gel. So it depends on the sort of the requirements of that.
Yeah, actually on the tube, when you have the tube, which is local application, in India we get the estrogel, which comes with an sort of a spatula where you can measure the amount you need to use. So whether you want to use 1 milligram, you want to use 2 milligrams. We use it a lot in IVF patients when we are doing thought transfers to prepare the endometrium. So we use the estrogel in those women also quite effectively. So it's the response I would give to the person who's asked this question. is that whichever gel you're using, there is a literature inside which will tell you how much of the gel contains how much of the estrogen. So I think in different countries it would probably be a little different depending on the brand available over there. Then they asked the other question was, what is the role of norethistron in controlling bleeding? Do you normally recommend it now?
Well, norethistron is a very effective way of controlling bleeding. It produces very rapid endometrial transformation. And that can be achieved usually just with a 5 milligram dosage used for 12 days, although sometimes we use up to 10 milligrams or even greater for greater bleeding problems. But there are two problems. One is that it, for women with PCOS, it's quite an androgenic progestogen, and so it may exacerbate their hirsutism or their acne. If you have concerns about somebody who's perhaps quite obese and their prothrombotic risk, we know a small amount of norethistron is converted to ethinyl estradiol, and that could potentially increase their risk of thrombosis. So it might be better to use a more metabolically friendly progestogen such as dydrogesterone in that individual, or MPA.
Or what?
Or MPA, Provera.
Yes, MPA, right. The next question is that if there is heavy bleeding and the endometrium is thin, what would you like to give her? Probably the progesterone may not work.
Yes, it's perhaps less likely to work with a thin endometrium. Again, it depends, what the scenario is, because we know we're only taking a snapshot of that particular time when we do the scan, and it may be other times the endometrium is very thick. I had somebody in my clinic a few days ago who had a very cystic endometrium when we first scanned her, but she was scanned mid-cycle, and the endometrium measured 12, 13 millimeters, and we scanned her post-bleed, and the endometrium went down to 2 millimeters.
Absolutely.
So progestogen may still be of some benefit, but otherwise the Mirena can be tried in that situation to control the bleeding. Or if that individual, obviously fertility issues have to be taken into consideration. If she wants to try for a pregnancy, then I usually tell them to hasten their attempts to do so.
Yes. But she says, "Doc, I'm bleeding. What do I do?"
Well, again, using tranexamic or mefenamic acid is another option, just to control the bleeding at the time that the periods occur.
Yeah. Have you used any time vasopressin analogs? They are usually used in patients with bleeding disorders, but I've never used it. But have you any time?
I've been involved in the management of a patient who was given desmopressin. She had, I think it was a von Willebrand's bleeding problem, which she bled very heavily, and other methods were not very effective in controlling her bleeding. But I don't have great experience in using desmopressin or the other vasopressin analogs.
Okay. So I'm trying to ask only the questions which fall within today's scope, because there are so many other questions with use of metformin with fibroids, with diabetes, with etc. etc. So would you like to say something about insulin resistance and the abnormal uterine bleeding?
Insulin resistance seems to be the root of all evil as far as PCOS is concerned. And we know that the whole thing is driven by it. So the most important. That's why the most important thing is to try to achieve some weight control. But it's our patients, as you know, complain bitterly that they're trying everything, but because they're insulin resistant, they find it very difficult to lose their weight. They're doing more exercise. They're watching their diet. So that's where I don't think we should, as we say in the UK, throw the baby out with the bathwater. I think that insulin sensitizing agents like metformin still have a place, perhaps not as a long-term solution, but as a short-term measure. And I think perhaps we haven't used metformin in high enough a dosage. So often it's used at a dose of 500 milligrams twice a day. Often you need to go up to a gram TDS to see the benefits. Of course, the rate-limiting step is where they feel quite nauseous using such high dose. And then you could argue that's the way it helps with the weight control, because then they don't feel like eating.
Nausea.
They feel nauseous. But the other agent, which I think does require more research, is myo-inositol. And we have a preparation which you've probably heard of called Inofolic, which contains myo-inositol and folic acid. And that's the preparation we use most commonly in women with polycystic ovarian syndrome. 2 sachets a day, minimum of 3 months, usually up to 6 months to see a benefit. And it can be combined with another insulin sensitizer like metformin. And the combination of those two and all the other dietary interventions usually has a better outcome than just trying diet alone.
You have inositols in UK?
Yes.
Are they available?
Yes. Not to prescribe, but they can purchase it over the counter at the pharmacy.
All right. We do have a lot of preparations.
Yes.
We have a lot of inositols in our country with various combinations.
But I think you'll agree, and whenever I speak to anyone in this field, we need more research.
Absolutely. The trouble is we find doing research in our country, we have difficulty in getting funding for such research. It's only the institutes which are associated with the government can do that kind of research. But because it costs quite a lot of money to do it, to do a good randomized control trial, and therefore somehow, and the kind of products we get here are different products with different companies. So they have different combinations, they have different additions, they have different protocols, and so it's very difficult to decide on which product to use and what dose to use in treating a patient. So it's at this point in time, it's very challenging.
We need to investigate standardized product formulations, perhaps formulate them generically, and we need to also standardize outcome measures as well. Then we can form meta-analyses of the data, which will give us meaningful results, meaningful outcomes.
Yeah. So I think the questions are never ending. I think we have to call it a day now. And what I'm going to do is I'll send you all the questions.
Of course.
I'll send you all the questions, and then you can take it further. And we'll be able to help you with that. So I'd like to now say thank you very much to you and Nick for this very, very interesting discussion and lecture, and to all our online delegates for watching the program and sending in so many questions. I've got a thick sheet of papers here, and I promise you I will send all the questions to Nick and hope he has the time to respond to them. And I would like to thank MCure for their logistic support. I would like to use this opportunity to talk about the 2020 annual PCOS conference, which will be held in Bangalore between the 7th, 8th and 9th of August 2020. And do register for this program, and it will be as interesting as we've had most of our annual conferences. Another online certificate course which is on at this point in time on our website is called Expert, and it is related to infertility, and these are 6 modules, and once you do them and clear the 75 mark which you need for passing, you do get certified for this course through the PCOS Society of India. Anyone can register for it, and and apply for it. So everything is available on the website of the PCOS Society of India, and we need to once again say that everything you need to know about PCOS, you will find it over here on the website. In the meantime, I'd like to thank again Nick and say a goodbye to you. It's 9:30 in the evening here, and I'm sure everyone's ready for dinner. Probably you will get ready for dinner too. You have early dinner, don't you?
Yes, indeed. Low GI dinner, low glycemic. But I'd like to say thank you to you, and thank you to everyone who's listening. Good evening there, and I hope that we get the opportunity to do this again in the future.
We will. Thank you so much. Bye-bye.
Bye-bye.